everyone. Good morning, good afternoon. Um, and yeah, there's no snow in Miami,
Yeah,
so
no. That would definitely be a sign of the apocalypse if there was snow in
yeah,
Miami.
that would. Actually, there was in North Miami this week.
Yeah.
Well, North Florida, not Miami. Thank you, Wu Yu, for this amazing opportunity. It's really nice to be here, and it's beautiful here. I love the weather. Amazing. So, without further ado, we're going to get into NK, which is, when I first started learning about NK in university, I thought, okay, this is cool, but I'm never going to see this. It's never going to happen. Like, this is something I need to know for boards, and that's it. And when we started getting more and more awareness about NK, I feel like I see it all the time. What about you?
So I agree, and I think we tend to think NK is neurotrophic ulcers, right? They've actually gone to the ulceration formation, but NKs comes in that's the final step. What we're seeing in NK is the patients who have decreased corneal sensitivity, right? That's what I'm seeing a lot more of because I think I'm more aware of it now. But we always just think about NKs, those central ulcers, and patients who've had herpetic infections or have diabetes and they've got fifth nerves. That's what we tend to associate with NK. Right? But
And that's what we
NK
were taught,
Yeah,
right? I
absolutely.
feel like that's what we thought NK was. And we do realize now that that is what can happen to our patients if we don't do anything about it, if we don't catch it early. And I really think this is optometry related because we're the primary care eye care practitioners. We're the ones who can catch these cases early. And so it's really up to us to save these patients. And with all this awareness about NK, I feel like it's really changed how I look at patients and how I practice, eye care.
Yeah. How many of you do corneal sensation testing on patients on a regular basis? And Corey, how do you do it?
So I'll typically do a cotton wisp. In our practice, we have a Cochet Bonnet, but honestly, the cotton wisp is super easy. I am excited about some of the non-contact ones, like the Burl Engines one.
Yeah.
But honestly, cotton wisp.
So for me, it's actually non-waxed floss.
Same.
Yeah,
But
so
here's a
it was
better
interesting
question.
as I walked into one of the rooms in Alaska, and I'm going, "Why is there floss in here?" I'm going, well, "I remember why floss is in here." And it's the non-wax floss is what I typically use. I just was weird that I saw the floss, and I'm going, "Oh, I'll just floss my teeth while I'm here." I'm going, "This is really crappy if there's no wax on it." But I actually use the floss on it. But I
Yeah,
think cotton whisper work perfectly fine too. But remember, it's a comparison. Right? Always do the eye that you think is maybe less affected, just so the patient can actually have some sensation to it, and then do what the eye you think might be more affected by it.
Yeah, I remember when my staff saw that I ordered dental floss, they were like, what's going on?
Yeah, you're gonna start a dental practice too?
Yeah. So here's a better question even. How long, Corey, does it take you to measure corneal sensitivity?
Few seconds.
Right. And I think that's really the key because, well, we know that the cornea is really like the front surface of the eye. It's like the shield of the eye, right? And it helps us protect the eye by having reflexes like blinking, tearing, right? So if we lose sensitivity in that cornea, then it could potentially get injured. And my best analogy when I talk to patients about NK is like, I tell them, imagine your hand didn't have sensitivity. You'd be more likely to burn it. You'd be more likely to injure it. And so that's a really good analogy. How do you tell your patients about
Yeah,
that?
I tell patients that whenever they get a speck of dust in their eye, what does it feel like? It feels like a boulder in there. So there's more corneal nerves in your cornea than there's any other part of your body, which is why it's so sensitive, right? Why patients are very adverse to putting things in their eyes because there's so many nerves there, right? So for me, if they're not feeling anything, then that's a bad sign because there should be lots of sensation to the cornea. There should be.
Exactly. And so what's really interesting is that there's this constant communication between the nerves and the corneal cells. So we know that the corneal cells regenerate, right? They slough off and then they regenerate. But that really relies on the proper functioning of the nerves, right? Because if there's a problem with an innervation, then there's no one to tell the corneal cells to regenerate properly. And also you lose your blink reflex, your tearing reflex, things that are so important to maintain, good composition and proper ocular surface.
So to that point, that's why it's been so hard to get dry eye products approved in the US. In the US, the FDA requires that you have not only symptoms, but signs as well. So you have to take care of corneal staining. Well, we know there's a disconnect between those two. So you're having patients come in who are highly symptomatic and their tear breakup time is 12 seconds and there's no staining, but they're highly symptomatic. Then you have your patients who are 4+ staining and no symptoms, right? Because now at that point, the corneal nerves are shutting down, which makes it very difficult to get a product approved in the US because you have to show improvement both in corneal staining as well as symptoms. Well, those are hard patients to find, right? So to kind of Lisa's point is that in your patients with dry eye, they may go, first of all, we should be calling it watery eye syndrome, not dry eye syndrome, because everybody has watery eyes and they're going, why are you telling my eyes are dry? They're watering. Well, that's the reflex from that. In addition to that, they may not be symptomatic, right? Because at that point, the corneal nerves are shutting down.
So what is NK? And NK is classified as a rare disease in the US. I happen to think it's underdiagnosed. And the reason is, again, because when we learned about NK in school, it was that ulcer, it was that corneal melt, which again will happen if these patients are not detected early and not treated. But NK is a lack of corneal sensation or decrease of corneal sensitivity that results in breakdown of the epithelium. And then if that's not treated, then it leads to a KED, so a corneal defect that's non-healing, and then that can get infected, and then that can lead to the ulcer, and that can lead to scarring, and then breakdown of everything. So essentially, it's, again, our job to catch it early. So how do you know what NK looks like? Again, this is the picture that we all know, right? That we all learned about. But basically, it's characterized by changes in the corneal epithelium. Again, irregular, dry, cloudy corneal epithelium, PEK. And then other signs and symptoms would be dryness, which is interesting, but it's not the typical dryness that Dr. Lonsberry was referring to. It's not like pain, it's not burning. What do your NK patients usually? Yeah.
They're not presenting with anything.
They really don't usually have symptoms. A lot of the time it's fluctuating vision because, as you know, the ocular surface is not regular. If it's injured, then patients are not going to have good vision. If they have SPK, for example, they're not going to have good vision because the ocular surface is all irregular. Photophobia, so they could have light sensitivity, reduced blinking, blurry vision especially, and I find that fluctuating vision has really been a common symptom. So what leads to this? So there's a lot of different underlying conditions that can lead to a loss of sensitivity. So one of the main ones that I see is herpes. I feel like if you have a patient with herpes simplex or herpes zoster, you should automatically suspect that they have NK. But other things that are really common, chronic dry eye can actually lead to a loss of sensitivity. Chronic contact lens wear, so patients who've been wearing contacts forever, glaucoma medications is a big one. These patients are using preservative on that ocular surface 2, 4, sometimes 6 times a day forever. LASIK patients, any other examples?
For me, it's diabetes.
Yeah.
It's one of the ones I tend to think about a lot. We're going to pick on Corey again. What patient would you kind of think about doing corneal sensation testing on?
So at this point, it's become so common. I've done it on like all of my dry eye intakes. However, for me, it's a lot of refractive surgery patients, diabetics, obviously. Yeah. And I always ask about a history of herpetic infection. So I'm talking even cold sores, not even of the eye. Those are my 3 big ones. Any type of ocular surgery, diabetic patients get. So my top patients I'm looking for any signs of NK are diabetic patients because of neuropathy, patients with refractive surgery, or if they have any history of herpetic infection.
So the other one I'd throw into that group is autoimmune disease. So your patients, they have RA, lupus, those ones, I mean, 90% or more of your patients with RA are going to have dry eye issues, right? So to me, that's another one I would throw into that mix is your autoimmune patients. And again, it takes you 30 seconds to check corneal sensation on them. Absolutely be checking corneal sensation if you find any staining, but also my big one is diabetes. I think that for me, the fifth nerve component to it is an overlooked component of patients. They don't actually have to have the whole palsy issue. They don't have to have the down and out, the lateral rectus palsy and so on. They can have reduced function of the trigeminal from that. The other one I would throw into the mix is the autoimmune disease one.
I'm sure everyone in this room has seen that LASIK patient come in for like an annual and you see the SPK and they have no complaints. It's just that I remember when I first learned about NK because there's been more and more awareness lately because of new treatments. And I was like, I've definitely seen that. Like, I've definitely seen that patient. And I'm sure if you guys think about it, you've also seen them. And again, catching early is really key. So again, NK is a decrease or absence of corneal sensation or sensitivity. And the hallmark sign or that, board's phrase is stain without pain. So again, if you see a patient in your office and you refract them, it's whatever, more or less, like you're not getting good vision, and then you go to your slit lamp and you see SPK, but they didn't come in with complaints, red flag. But a lot of the time, those patients have already have been anesthetized, right? They've already had proparacaine inserted. So what do you do in those cases? You have to bring the patient back in order to test sensitivity. How many people here see patients once they've already been dilated? Right, so that's tricky. So if you're seeing SPK, they've already had proparacaine instilled, then you can suspect NK, but you do have to bring them back on a different day for testing. So if you're suspecting it, let them know, schedule them for a follow-up. What do you do in those cases?
Yeah, so those patients that come in, basically we always want to check VAs on patients before we touch them, but that's all they do really at that point. They don't check pupils, they don't do any lights. It's just basically they check VAs, and at that point, well, then they come to me.
So again, if you're seeing a patient with staining that didn't come in with complaints, think about it. Staining is painful. Has anyone here ever had staining on their cornea? No? Everyone's, yeah. It's painful, right? I've had it. It's very painful, very uncomfortable. If they're not coming in with those symptoms, red flag. So we touched a little bit upon testing corneal sensitivity. So there's qualitative, there's quantitative. So qualitative would be, again, with your cotton thread. So you just take a little cotton thing and you bring it out a little bit so it's like thinner on the tip. Or you can take dental floss, again, non-flavored, non-waxed. And then there's the Brill aesthesiometer, a Cochet-Bonnet, which will give you actually quantifiable results. Yes.
That Brill, when you're testing 5 areas,
Yes.
are you able to do that with that Brill?
Yeah. Yeah.
So the question is, can you
I'm
change
sorry.
multiple areas with the Brill? And yeah, you can.
So yeah, let's talk about testing sensitivity. So when we're working up a patient for NK, when you suspect NK based on the case history, which is when you should start thinking about it, your slit lamp exam is going to be there, and your corneal sensitivity is another step. So I feel like we're already doing 2 out of the 3 parts, right? We're all taking case history. We're all using a slit lamp, right, with fluorescein. All we're missing is that corneal sensitivity. And as Dr. Lappin said, Dr. Blonsberry, it takes like less than 30 seconds. And the thing is, you can measure various quadrants, but if you have decreased sensitivity in even just one quadrant on one eye, it is considered a decrease in sensation or neurotrophic keratitis.
So I think that's a good point.
Yeah.
So I don't always check all 5 quadrants, honestly.
Well, you don't have to,
So,
but
I would love to say that I'm always doing it, but I'm not. Do you check all 5 quadrants all the time?
I do now,
Yeah.
because I started catching a lot of
More
stage
peripheral?
1, a lot of stage 1 and peripheral
Yeah.
areas. So I will say though, that's
Do you give him the mic, maybe? Yeah.
So I'll test in all 5 frequently now, because especially at stage 1, I'll find it's normally in one area. And that's why I love the point where you mentioned, everyone saying, oh, this is stain without pain, right? But at stage 1, it's so like dry eye that a lot of times I'll have dry eye like symptoms. And I'll find that normally, yeah, I feel it not quite as much. And it's one of the quadrants. So that it does add a little bit more time, I'll say, to do every single one. So if you're just using it as a screener, then, you could probably check centrally. But if you have any suspicion, like you mentioned, autoimmune patients, big time, I would say, be checking all the quadrants for that.
So I will say that I typically do central, right? And I guess maybe I've done it on all quadrants in someone who maybe doesn't have the sensation to it, but I agree with Corey that I probably should be checking more of those peripheral ones because those are probably the ones I'm missing. I will say that I default to typically central for me.
what's cool about testing sensitivity is that it's interactive, as you mentioned earlier. It's something that you can ask your patients, hey, are you feeling this? Yes, you're testing their blink reflex. Like if you get something touching your cornea, you're automatically going to blink. So you can see how they respond. But you can also ask them, how does this feel? How does that feel? And they'll know that they felt it more in one eye than the other. They'll know that they felt it more in one quadrant than the other because they can feel the difference, right? That one doesn't feel quite right. That one doesn't feel like the other eye. So get them to interact, to participate. That feedback is actually really important. And it will give them an idea about what you mean, right? Because again, if they're not feeling properly, then they can't adequately protect their eye with their eyelids, with their tears, or their cornea, the regeneration of cells, right? And so that's the key component. So let's go over this case that I saw. This was a Hispanic female. I saw her last September. She actually was referred to me for a scleral lens, which is my specialty. I focus on specialty contact lenses, but as you guys know, that's an ocular surface thing where I see a ton of dry eye. I think you said all your patients have dry eye. All my patients have dry eye, and a lot of them have NK. So she comes in, she had a cataract surgery on the left eye. She then had a bacterial ulcer, and then she's followed by a cornea specialist at Bascom Palmer. Her visual acuity was 20/30 on the right, 2400 on the left, and with correction, it was about the same. So I actually do have a Cochet-Bonnet aesthesiometer. So Cochet-Bonnet, again, we probably learned about in school. It's usually done in research facilities, but I had a patient buy it for me because he absolutely wanted to get approved for oxybates, and his insurance was like, you need this test. So he actually found it on like eBay or something and gave it to me. So I was like, all right, thanks. So now I do it. And so this is what I found. So if you have more than 4.5, if you have 4.5 centimeters or less, it's considered abnormal. So I guess you could say it's abnormal on both, but let's focus on the left eye because that's really what it looked like, okay? So you can see this huge KED centrally, which was again developed after her cataract surgery on the left eye. She's been followed at Bascom Palmer. She was on fortified antibiotics. She was on topical antibiotics, but again, I tested her sensitivity and I'm like, she had nothing. Like she didn't feel anything. She was just uncomfortable. She was tearing. She couldn't see well. She was panicking because she was 2400, and after cataract surgery, you're expecting a little bit better than what it was before. So it was definitely, she was really, really panicked. So I did 3 things for her that day. I did fit her for a scleral lens, but a scleral lens takes a few days to arrive. And so I knew like a scleral lens, again, it has this reservoir of fluid between the lens and the cornea, and it bathes that eye in this fluid, and it can help the eye heal. It protects the eye from external factors like the eyelids, friction, dust, bacteria, things like that. So it's definitely something I wanted to do to promote healing. I did do an application for Sirnetterman, which is a treatment that helps restore NGF, endogenous NGF, which is basically restoring corneal sensation and helping her have normal sensitivity again. But that typically takes a few weeks to sometimes a month or more to receive. So that day after the fitting, I actually put a Procara on her to promote the healing of her cornea. So I followed her up, removed the Procara. We still didn't have the scleral lens, but her cornea was a lot better. And then the following week, I gave her the scleral lens. She needed a lot of training. Again, she was really just panicked about her eye. She was really upset about the surgery and just not a calm patient, and I understand just because of everything she's been through. So we had to train her multiple times how to put it in this lens. She was really nervous about putting something close to her eye. But on the 22nd of October last year, she was approved for Oxervate, and I think like everyone was crying in the office. I was crying, my tech was crying, the patient was crying. We were all so excited for her that this would actually, that she was getting her treatment. So again, we talked about a scleral lens. These are the parameters, this is a design I used. What the lens does, obviously it helps the patient see. That's what a scleral lens is usually used for in a regular cornea. That's like the main indication that we think of. But in this case, it's really restoring the front surface. It's really helping to protect the front surface of the eye and prevent further breakdown, okay? But, then she was approved for Oxervate. Oxervate is a drop that has to be used 6 times a day for 8 weeks. So it's a lot to put on, remove the lens each time. Obviously, a lens would limit the absorption of the drop, so it has to be removed. So during the time of her Oxervate treatment, she actually wasn't using the lens, but right after finishing it, she put it on again. So we continued doing some training because, again, she was having a lot of trouble putting it in, taking it out. So you can see how many trainings we did for her, but essentially, we again submitted another application for Oxervate, which is off-label, but she still had reduced sensitivity in this case, so we wanted her to have another application, and she was approved for another round. So you can see what her cornea looked like in January of this year. So a lot better. Again, we did Procara, we did Oxervate. She's on her second round, and she's using a scleral lens. So this is how I manage this case, and the patient's doing really well. So.
What's her vision now?
It's about 20/50 still. So we're still working with her. You can see it's not perfectly, smooth, but we're working on it. Yes. It was a reverse geometry lens with toric peripheral curves.
I didn't understand one word that you said in that last sentence.
She didn't have allergies.
Okay, perfect. She had glaucoma, I would understand. But the reverse geometry, peripheral, that's just a bunch of jumbled words at that point.
Yes.
When they have stage 1 and significant E,
Yes.
do you feel that might help you get the Oxervate going?
Yeah, anything you can.
So the question.
Oh, I'm sorry. The question is, in the early stages, if you just have PEE without pain, so you're detecting stage 1 NK, which we'll talk about the stages in a little bit, but would you start MIEBO, which is a drop that helps, prevent evaporation of the tears or promote, lubrication of the ocular surface? And the answer is yes, whatever you can do to help, the eye heal while you're waiting for Cernedramine to be approved. In this case, I use Procara, but you can use MIEBO, you can use preservative-free artificial tears, you can use ointments. Some patients even do a tarsorrhaphy while they're waiting. So there's a lot of things you can do. I have the scleral lens, and I knew I could get that to her before it was approved, but whatever you want to use to promote healing of the ocular surface.
Have you had any experience where the staining was improved with MIEBO using?
Have I had any experience
use
where the
MIEBO,
staining has been improved with MIEBO? I haven't personally used MIEBO with NK, but I think it's a great idea, especially if there's an evaporative component to their dry eye, or if they.
So I would say, I would have said until even just a couple months ago that I've never seen improvement with lubrication drops for staining, except I've had a patient recently that did. And I tried to get him to go to Oxervate, but he was refusing to do like any of that stuff. And so we did heavy lubrication, and I'm going, he's going to become neurotrophic and so on, and he actually came back with improved. It's probably the only patient I've ever seen.
Just
That.
artificial tears?
Yep. Yeah. So normally I would say artificial tears don't solve any issues, they just make the patient feel better, but he had actually significant improvement in it.
But it's reasonable to think that if you're not helping, the corneal sensitivity problem itself, which is the underlying cause, that it will just recur even if you help it heal at that specific time.
Them until they get the
Yeah.
Correct,
Yeah.
because if I had just done Procara, then I would have had to just use Procara every month. You know what I mean? So
Yeah.
it doesn't treat the underlying cause, it's just palliative, if you will. Yeah. All right, Dr.
So this is, I'm not one of my patients, Dr. Liz Lane, who's up in Alaska. So I'd come up to Alaska, and it was kind of like later August, and she said, Blair, I want to run this case by you. So she had a 60-year-old male patient who had just recently had gone through quadruple bypass surgery, came in 20/25 in his right eye, 20/20 in his left. He had reduced corneal sensation in that right eye, and you can see that there's actually a neurotrophic ulcer there present, and not really feeling it, just other than some kind of irritation in that eye. So she did antibiotics on him, did a bandaged contact lens with heavy lubrication. Oh, no. Comes back, patient's feeling a little bit better, but kind of limited improvement, not really a ton better. At that point, put an ambio disc on to see if we could improve that ulcer that was there. Comes back about a week later, again, slight improvement of the ulcer, applied a bandaged contact lens again, antibiotics, heavy lubrication, comes back with no changes at that point. Now starting into things like CEQA, et cetera. And this is kind of where I came in that August 7th time period. That's where I kind of got involved in the case. And she said, what next should I do? And I'm going, well, put him on oxybate. And she goes, no idea what that is. Like, what's oxybate? And I'm going, the only FDA-approved product for NK. And she goes, I still don't know what you're talking about. It's kind of like the reverse geometry voodoo lenses that you were doing just a minute ago. She's going, you're speaking, but I don't understand the words coming out of your mouth. And I said, well, oxybate is approved for patients with neurotrophics. I said, the challenge is getting it approved for it. So I said, it's going to take time. So I think we should go through this process. So applied for oxybate at that point in time. Didn't get approved for about a month. Interesting enough, though, the insurance they had paid for all of it, which is $25,000 was the $24,900 and some dollars for it, which was amazing that actually was approved for it. We didn't have to go through the whole patient assistance and so on. Started on the oxybate. Again, it's 6 times a day, so every 2 hours to 6 times a day for an 8-week time period. And you can see that a week later, with significant improvement, within 2 weeks, it was gone. Right? So for the several months before that, doing bandaged contact lenses, doing some form of like AmbuDisc, so doing an amniotic membrane, doing heavy lubrication, all that kind of stuff really didn't change this. Within 2 weeks of being on oxybate, that neurotrophic was gone. Right? So for me, this was one of the best cases that I was kind of involved with, which was actually one of my patients, to see such a rapid improvement. And now I think the practice in Alaska is one of the bigger prescribers for, because we have so much dry eye in Alaska, that it's actually a great product for us to use. So to me, the fact that Dr. Lane had taken the pictures and had seen the progression, to me, it was just kind of like a slam dunk for this one. Like literally all the things they had done before didn't work until oxybate was put on the system for it.
Did you keep it up the whole 8 weeks?
Yep, no, did the whole 8 weeks. Yep. So we just saw the improvement at the 2 weeks that had been pretty much gone, but you do it for the entire 8 weeks.
Great case. So again, the treatment, what we're trying to do is promote corneal healing, avoid complications. What are the complications? Again, further breakdown of the epithelium, non-healing epithelial defect, which can lead to infection and corneal melting. Okay, so it is a progressive disease. And just like everything else that's progressive, whether it's glaucoma, AMD, whether it's keratoconus, we want to halt that progression early. So early detection, and again, that's so optometry, because by the time it gets to ophthalmology, it's far gone. So we are the people that can help prevent this progression. Okay, so again, preservative-free eye medications. So we're talked about lubricants while the patient is getting approved, hopefully for Sernedrimen. You can use steroids, but topical NSAIDs should be avoided in these cases. So what are the stages?
So why the topical NSAIDs being avoided?
Because
Yeah, so interesting enough, the newer generations are not likely going to increase chances for corneal melt, but the original ones had to increase, or any sick corneas, or increased chance for corneal melts on them. So I still think that in this case, you probably would avoid the NSAIDs on that one. It's probably, if you're using a newer generation, the levoprolensa and stuff, you're probably not going to get the corneal melts, but still I would probably avoid them in this case, because you might be thinking there might be pain involved, so you want them on a topical NSAID to reduce the pain. I would avoid it. There's a kind of a true epithelial defect there that you're going to want to avoid your topical NSAIDs. Yep.
Few questions from online. How much does contact lens wear affect desensitization?
that's a good question. I don't think there's any measurable evidence of that, but we do know that chronic contact lens use can lead to a decrease in sensitivity. How much is still not known. Really.
Thank you. Is it true that when Oxervate starts to work, the pain may come back with innervation?
Yes, and that's actually a really good sign. Some patients do complain of pain with installation of Sernedrimen, and that's actually like, yay, you can feel again. That's great. And so you really have to coach your patients through that process, because a lot of them will panic when they start feeling that pain, and not all of them feel pain. I think it was about 16% of patients in the studies. But it is a good sign, because it means that they're starting to react normally, that their cornea is starting to feel again. So yes, good sign, and it is something that you will see with your patients.
For corneal sensitivity testing, does the patient have to look straight ahead, or are they looking in different directions to test the different quadrants?
It's a good question. It depends on the device you're using. But let's say Cochet Bonnet or dental floss or cotton wisp, they can look straight when you're testing the central and nasal and temporal quadrants. But if you want to test the superior or inferior, I usually have them look up or down.
Do you know if Ortho-K patients have reduced corneal sensitivity compared to other contact lens wearers?
These are great questions. I haven't seen studies on Ortho-K causing a decrease in sensitivity.
Blair's like,
No.
Again, another word
question.
that I'm not too sure what you're talking about.
Last question for today, for now.
Yeah.
Any tips on making Procera more desirable? My patients want no part of it. We do the Procera Slim, but between comfort and driving, it's a lot for patients.
So they need to go to the new Cam 360 if there's an issue. So you guys know about Cam 360? So this is basically a contact lens, right? So it's a very thin membrane that's, now the debate is whether or not you put it on the eye, put the contact lens on top, or actually put it in the contact lens, but effectively it's a soft contact lens. They used to have the powder. The powder works really well too. So there's a ground up, basically amniotic membrane. You actually put it into liquid form, put it in the contact lens and put it on the eye. So at that point, it's a soft contact lens, right? So you're not talking about the rings and all that kind of stuff. So the Cam 360 is kind of the newest one from the Procera line. And effectively, it's you have to be careful on it because it's a very thin membrane on it and it will fold up. So you need to kind of smooth it out and then put a contact lens over top of it to stabilize it. There's also the powders too. And so at that point, it's basically a soft contact lens.
There's a question that actually came in on that. Do you use Cam 360 as your first line therapy for NK?
That's a good question.
So Cam 360 was a limited release it's now more available, but it was a limited release for certain practices to be able to get hold of Cam 360, and we weren't one of them. So I've had limited experience with Cam 360 in the sense of how many patients I can put it on. But I think, yes, I would at this point in time.
I'm going to answer the question from a perspective of, let's say you do want to give the Procera Slim with the ring. You don't have the iCam 360. Let's say you have a stock of Procera Slim, and this is the membrane you want to use. How do you convince patients to use it? Or to have it inserted? Basically, you say, listen, I can give you antibiotics and drops and the cornea will get better. It's like gonna get better so much faster. This is what I would do if I were you. You can tape the lid down a little bit so they feel it less. And you can just tell them, listen, this is what your eye looks like. It's really gonna improve significantly if you use this. I would highly recommend it. Of course, you can't force them, but you can make it as comfortable as possible by just taping the upper lid a little bit.
Now, I might be speaking out of turn, but I think with Cam 360, that even if they keep it on for 24 hours, almost all of it's absorbed within like that 24-hour time period. It's not like the 3 or 4 days that we're worrying about some of the original Proceras. Like you really need to be able to keep it on the eye for at least 24 hours. And if you get that, then the majority of that amniotic membrane is absorbed into the system.
So let's go back to our stages, our Mackey classification. So stage 1 is, we described it as that SPK, again, no pain, right? Or decreased sensitivity. And stage 2 is that persistent epithelial defect. And stage 3 is the severe. It's the one that we learned in school, the one that we'll probably not see, okay? Or if you work in an ODMD practice, maybe you'll see it more. What I like about these stages is what's written at the bottom here. It's what we're trying to do at each stage. Stage 1, we're trying to prevent a persistent epithelial defect. So we're trying to prevent further breakdown of the epithelium. In this stage 2, we're trying to prevent infection. And stage 3, we're trying to prevent perforation. So it's really, what can we do to make this less bad, or what can we do to prevent progression in these cases? And I think that's really key, again, when you're talking about a progressive disease. So again, stage 3, corneal ulceration, stromal melting, or perforation, which is crazy. So these are some treatments. Obviously, punctal occlusion to help increase the amount of tears on the surface of the eye, preservative-free drops. You can use ASG, you can use PRGF. You can use.
Could you go back one step?
Yes, of course.
So for the punctal occlusion, I think that's one thing that we really overlook, particularly with our dry eye patients. I think that whole original Delphi panel that came out said that, you know, that stages, the 1, 2, and 3, at that point, before you're doing punctal plugs, you have to do anti-inflammatory, so we got away from doing punctal plugs. For this one, I don't know if I would do a Freeman type on there because I don't want any more irritation. I probably would do something like a Laquafil for that one because I think that, to me, that would, I just have seen a lot of patients now that get the irritation from that. And since they're not feeling it, I think it can cause damage and they wouldn't know that, right? So I just removed permanent plugs from someone just last week. I take them out because they had the irritation. With your neurotrophics, to me, they're not going to feel it. And so now you potentially have nothing that's causing an abrasion on them. So to me, if you're going to do punctal plugs, and I think that we're overlooking punctal plugs on patients, particularly in your NKs, you want to keep more on the eye, something like Laquafil and stuff I think would be a good option.
Agree. I think a basic treatment for patients, whether they have dry eye or NK, any epithelial breakdown, punctal occlusion, Laquafil is a great product, and preservative-free artificial tears like step 1, and then keep going.
Or unless you had that students you talked about last night who put a permanent one and pushed it
Oh,
down into the system,
oh my gosh.
then they don't get irritation from that too. But
Yeah,
now they've got
maybe-
a plug that's actually in the.
Maybe don't ask a third-year student to do it. So again, amniotic membranes is something you can do. I talked about scleral lenses. I'm going to talk more about scleral lenses this afternoon for dry eye, but scleral lenses, this is an OCT, an anterior segment OCT of a scleral lens on the cornea. And you can see that reservoir of fluid. So I'll just show you with the laser pointer. This is the cornea. This would be the lens on top, and that reservoir of fluid actually hydrates the eye the entire time that the lens is on. So it does correct vision in irregular corneas, but in these cases, it provides hydration, constant hydration while the lens is on, and it protects the eye, restores the ocular surface. So it is such a good tool if you have access to these products. And so you can see the improved ocular surface there by using a scleral lens. So again, look at the initial ocular surface, and then after prolonged use of the scleral lens, how much that improves. So we talked about oxervate sernedrimen. And so I don't know if you want to talk a little bit about
Yeah.
that.
So the point for this for me is that original talk that Lisa was talking about was that kind of, if you don't have proper corneal nerve stimulation, it's going to result in epithelial defects because there's not that communication between the two of them. So what you need to do in this case is kind of reactivate the nerves, which is why there's pain going to kick in later for them. Because you need that constant communication. You need to regenerate those nerves in order to get a solid epithelium in play. And to me, so I actually got to meet with Mr. Dompe, who's from Italy. He actually was at AOA. When he was in Washington, they actually put on an exhibit of some of Da Vinci's like original drawings and stuff, and he actually brought that. And so I got to meet with him, and he was the most down-to-earth guy you've ever met. And he's going, we know this is an expensive product, but he said, what we do is we take that money and we reinvest it back into research. And he said, we are committed to making sure patients can get this product. So yes, they're going to try to file it through insurance, and yes, it can be from $25,000 to $75,000. But if they don't get covered by insurance, they will guarantee the patient for $50. He said, we are committed to making sure patients get this product to take care of this condition. So to me, it was not only did I think the product work, but there's someone who actually is head of a company is saying we are committed to making sure that this patients can get it. So to me, I just thought the combination between the two was just amazing from that. So to me, this is really where you need to go, and before they're getting to the ulcer formation, right? I don't say I've done a ton of ones, but I'm doing much more twos and waiting for them to get to the threes.
Sernedrimen at any stage of NK, don't wait for it to progress. If you have a stage 1, again, you're seeing that SPK patient, they don't have symptoms, their vision's fluctuating, test the sensitivity, you see it's decreased, apply for Sernedrimen because it will prevent the progression. And that's really what we want to do.
So I'm going to, have you seen people getting now trigeminal blocks? So I had a couple of patients that get trigeminal blocks because they have this neuralgic pain, and they get a trigeminal block. So what happens at that point? They lose sensation and their decreased rate. So I have a patient that we're watching really closely because her trigeminal pain was so aggressive that they had to do a block on her. So they basically killed the nerve that's there. So now she really doesn't blink anymore. And she's going, I had to do this because I couldn't stand the pain. right? So be careful that there's other conditions that you may not be thinking about that are linked up to, like herpetic infections and so on. The big one would be a trigeminal block that patients have done. And that one, we're really worried about her. Like she just doesn't blink anymore, right?
I think, yeah, go
Is this neurotrophic due to zoster?
Yeah.
Does that change your approach?
So if it's neurotrophic secondary to zoster, then probably not. Because ultimately, again, it's doing the same things that a trigeminal block would do, right? It's basically the trigeminal is not really functioning at that point. So to me, I think you have to be, again, as Corey was saying, if there's any history of zoster that affected the eye, then that's one I'd be really checking to make sure that they are actually bringing them in more regularly to make sure that there's no staining, that kind of stuff for them.
The best part, again, about testing for corneal sensitivity is that it really doesn't add to your chair time. And I think that's like a concern that people have, especially if they're seeing 20 patients a day and they just need to get them in and out. It really just doesn't take any time. So, yeah.
Couple questions. Any further treatment tips for those of us in Canada without Oxervate?
Yeah. So there was Oxervate was in Canada for a while, and then they kind of pulled it from the market again from Canada. I mean, at that point, I think you need to be talking about doing scleral lenses. I think you need to talk about doing, the Procaras, the amniotic membranes. We keep saying Procara, but amniotic membranes of any form to kind of see if you can heal that. But then at that point, I think so again, I tend to forget about sclerals because I don't do sclerals, right? So when any of my dry eye talks, I tend to forget about sclerals, but that's to me the ultimate is if you have those patients is that they need to be in a scleral. I mean, that's the same thing even if you're doing Oxervate on someone, is that they're going to be in a scleral later anyway, because Oxervate only works for a certain time period to heal it. It's not a one and done and they're good forever.
It's not
right?
the end all be all.
Right.
I do have a patient who we did an Oxervate application for, and a lot of the time the insurance is not going to want to pay, like they always do, right? And so they denied it. We appealed, they denied it again, and then they can do an application for financial assistance. In this specific case, the patient didn't qualify, so he could not get Oxervate. So we got insulin compounded at Bascom Palmer, and that's an option for. There's a really good study.
There's a couple of them out
Yes.
there right now. So you beat me to my
Yeah.
point.
Okay.
That was the other thing is to
Okay.
do topical insulin has been found to be really effective for patients. Again, if you want to just send me an email, I'll send you the papers if you want. I don't know if I can give them to you. You can upload them so the patients can have access. But that would be my next one is topical insulin. So I'm glad you brought that one up. But if you need papers, just send me an email. I'll get them to you.
Thank you.
Yeah.
So-
Another question on how long does it take to go from stage 1 to stage 3?
It really depends on the patient. I don't think that you can predict. It's like how long does a patient with an IOP of 35, how long does it take for them to go blind? I think everyone's different. Everyone has a different tolerance to.
And what's the underlying condition too?
Exactly. So
That's the
I
big part.
think you know that they're going to progress. You don't know at what rate. I don't think it matters. I just think intervene ASAP would be my kind of theory there. Yes.
Can I ask you a question on geology? I mean, we're in Arizona here.
Right.
A lot of people don't hardly drink any water. If they do drink water, they're drinking coffee or tea. So, of course, that doesn't help their lives. Is it possible that these people are getting this NK?
Part of just being healthy, right? So I tell patients why they're taking artificial tears is that your cornea to be healthy needs to be lubricated, right? So that's why we need lubrication drops. So I think hydration is an underlying issue for patients just health-wise,
I'm looking
right?
around the
Whether or
room
not there's a
and
direct
everyone's
link to that to
taking a
NK,
sip.
but ultimately I think that there's a link just by being hydrated and being healthy.
All right,
at
everyone
that
take a
point.
sip of water.
Yeah.
So just structurally, we know that sernedriment, BKBJ, which is the active ingredient in Oxervate, that is structurally identical to endogenous NGF. And endogenous NGF is what keeps that communication with the corneal, between the corneal epithelial cells and the corneal nerves. So it's kind of like their way of communicating, like their cell phone, right? So that's really what sernedriment does. And that's how it works. So it's approved, again, Dompé, it's been FDA approved since 2018. And I think the biggest benefit of having this on the market is all the awareness that it has raised about NK, which really is not something that I've looked for before the advent of this drop. And that's, how it comes. Every 2 hours, 6 times a day for 8 weeks. If they are a scleral lens wearer, I usually tell them just start the Oxervate in the morning and wear the scleral lens in the afternoon once they're done with the Oxervate. Some patients prefer just not to use their scleral lens during those 8 weeks.
Yeah, no, the whole point with Dompé is that once you're writing that prescription to send to the pharmacy, is you automatically kick in Dompé immediately. The patients have to sign forms, right? So don't let them leave the office until they've signed the forms, because then you're tracking them down to come back in to sign the forms. So do that on that first day. When you're saying, I'm going to prescribe this one, go to, is it Dompé Connect?
Yeah, or Connect to Care.
Connect to Care. And have them fill out the forms and sign them, because they have to be signed before you can submit them. And do that right off the bat. And if the insurance covers it, great. But then at that point, if it's not, then Dompé kicks in at that point. They actually do that process, right? They'll actually try to refile it with insurance. If it doesn't happen, they're already involved, and we'll set up the whole patient assistance at that point. But please do it on that day, because the forms have to be signed. And we've had to have patients come back in and sign. Just get them to do it that day. So do the Connect to Care on that first visit. And at that point, you write your prescription and send it off, or ERX it over. The likelihood is it's probably going to be denied. Right? But at that point, Dompé is already involved in the process, right? So that's my kind of tip, is sign the papers day one.
And if you don't have the forms, you can get them online. And if you want, just contact your rep. They'll drop them off. They have people everywhere to help. So definitely, get on that. Make sure you're looking for it. Again, early detection. This is what we do. We're primary eye care practitioners. So it's really up to us to diagnose this. Corneal sensitivity takes so little time. If you can test all quadrants, great. If you can just test one, that's fine. Just do it. You're already doing half of it by doing a slit lamp exam, and more than half by doing a history and a slit lamp exam. Just that third step is all you need to do. Anything you want to add?
So I was going to put a plug for Ocular Surface News, which I write an abstract for. The last abstract I wrote for was actually on topical insulin. So if you go to Ocular Surface News, the last article was actually on topical insulin. So it'll give you a connection right there. But I also send it to Stephanie too, some of the articles that are on topical insulin. That to me is, for a Canadian audience, would be a great one. But even if you have patients, it's been shown for these really kind of corneas that are just not healing, that topical insulin has been really effective for patients. So go to Ocular Surface News, look at the last one, the abstract will give you the article in there and gives you my rundown of that article, but that last one was on topical insulin.
So do they have to go to a university setting to get that, or how?
No. So the question is, do they have to go through a university setting? No, they just have to go through a compounding pharmacy. Yeah. So it'll tell you what the concentrations are, like 1%, I can't remember on that one. But they did comparisons of looking at with steroids and so on, and topical insulin was far more effective for patients. Yeah. But it has to go through a compounding pharmacy. And remember, not all compounding pharmacies will do topical drops. They need special fume hoods to do that. So you can have compounding pharmacies that will do skin preparations, but not necessarily topical drops, right? So you need to make sure that one can actually do the topical drops.
If you do feel like you want to get a cornea specialist involved in this case, in whatever case it is, you can definitely do that. I think the one thing is get the application started for sernedriment when you diagnose it, because it does take some time, and then come up with something that you can do in the meantime while you're waiting. Any other questions? Yes. How do you bill for what? Like medical or? Okay, that's a good question. So a lot of the time it's like you know, you're seeing these patients with NK, you're going through this whole process to try to get them Oxervate, and it's like, well, I don't get paid more, right, if I do this or not. But it's really the only thing that works well for these patients, and I just think it can really change their lives, and that's what we're here for. Honestly, I'll just bill like a medical visit with a diagnosis. You know, maybe I'll get paid, you know, regular eye exam, $90 or something from a medical insurance, but you're really changing the lives of these patients. Like they're going to be so thankful. And I think as a practice builder, you're going to be that doctor that figured it out for them, and they're going to bring their family, their friends, you know, and they're so grateful. They're so grateful. I don't know if your experience has been similar. So it's worth it. You know, that's what we're here for. We're doctors.
And the nice part about going through the Connect to Care is that then at that point, Dompe kicks in. So you're not spending a lot of time trying to do paperwork. You do the one and done at that point, and they're already involved in it. Yeah.
Well, thanks, guys.